Hi, I'm Tim Wiedrich, Section Chief of the Emergency Preparedness Response Section and the Health Resources and Response Section of the North Dakota Department of Health. This is our statewide hospital tactical call. We're doing this once a month now on the fourth Wednesday of each month at 2 p.m. Thank you for joining us. This is jointly sponsored by the North Dakota Department of Health and the Hospital Association. Tim Blazel is not with us today, and so we will just continue on and skip his opening comments and move straight into Dr. Connell to see if Dr. Connell has any information about the latest on monoclonal antibodies. Dr. Connell?
Yes, thank you so much. I'm going to attempt to share my screen. Okay, can you see it?
It appears to be on its way. We don't see it yet, but hope is running high that it's coming. All right, we have it now.
Okay, super. Hope is a great thing to have, and I think we all must possess that trait since we're still alive a year and a quarter into this pandemic. So thank you all. I think you may recognize this title slide because I provided this presentation before when monoclonal antibody therapy first became available. So I want to direct you to a few changes that have come up fairly recently and will likely affect your infusion practices. So we have added another monoclonal antibody product to the game. Last time I gave you guys an update, I told you about ETCVmab being added to bamlanivimab and not using bamlanivimab alone anymore due to concern for resistance of some of the variants to this monoclonal antibody. So even in combination, the two products together, bamlanivimab and ETCVmab, there is still some resistance imparted with some of the variant strains of COVID. So if you do the direct allocation process, you may see, depending upon what region of the country you're living in and what percentage of the various variants are present there, that bamlanivimab and ETCVmab may not be available to you. So those of you who may have this on your shelves, it is important to check with the CDC guidance on variants and look at your emergency use authorization that's been updated to reflect what the if there is significant resistance to that particular variant. So that's update number one. Sotrovimab is a solo monoclonal antibody product made by GlaxoSmithKline that has been recently approved for emergency use authorization. It's dosed singly over IV over 30 minutes. And it so far has no resistance with the various strains. Regeneron has also been shown to be very effective with the various variant strains. So those two are sort of the go-tos if you're in doubt. You'll also see in red that Regeneron or casirivimab and imdemivimab has been approved to be given subcutaneously if an IV cannot be obtained readily. So that's really important as well. In an upcoming slide, we'll see that these products may also be given at home, and I'll review that in a minute with you. Indications for monoclonal antibody therapy have also changed. So rather than having the section for 12 to 17-year-olds and then for adults, it's now available for kids who are at least 12 years old and 40 kilos and adults. And so that is a modification. also, the definition of being having a weight-dependent eligibility has significantly changed from a BMI of 35 to a BMI of at least 25 if you're an adult, or being at least 85th percentile in children. So that BMI of at least 25, I would say 85 to 90% or more of adult North Dakotans meet that criteria. Consider most everyone eligible for treatment. Pregnancy has been added to the high-risk group. And then the last bullet in red, this is very important, because even if your BMI is less than 25 and you have none of these other conditions, administration is not restricted to this list of conditions. Providers should consider the benefit to risk ratio when considering this treatment for patients. And they suggest things as race or ethnicity. We know minority groups have an increased risk for severe disease and mortality, as do those living in disparity. So really, anybody who tests positive who's at least 12 years old and 40 kilos ought to talk to their providers about whether they're a good candidate for monoclonal antibody therapy. And providers, for the most part, should probably be saying, yes, you are, and make this product available. This slide has not changed yet, but it needs to be updated, and I'm waiting for my partners at Department of Human Services, and then I will update the slide, and then I'll make the slide presentation available for everyone. So just note, if you have access to the former slide presentation or this algorithm, it's in the process of being updated to reflect these very new changes. As I said earlier, Regeneron can be given subcutaneously when IV placement would delay treatment. And we talked about before, one of the conditions for administration of this and eligibility for monoclonal antibody is you have to have symptom onset within 10 days of the infusion. And so that is still true. However, they're really reinforcing the importance of administering this medication as soon to time of diagnosis as possible. And I think this really reminds me of what we do with Tamiflu for influenza. I think the rules are administer it within 48 hours, within 24 if possible from symptom onset. And so this is where we're going with monoclonal antibody infusion for COVID-19. So if you're going to have to wait a day or two to get your patient to a facility where they can have an IV placed, or if you tried placing an IV and it's not working, and you have Regeneron available, you can give it subcutaneously in 4 separate injections. So keep that in mind. This also means that it may be given in the home, as long as you meet the criteria of having medications available to treat severe infusion reactions, including anaphylaxis, and the ability to activate the emergency medical system. So a home nurse armed with those pieces of equipment can certainly deliver this medication at home, either intravenously or, like I said, sub-Q. And as I recall from one of the webinars I recently attended, reimbursement by CMS for home administration is actually higher than other areas. As far as the allocation and acquiring process, this is unchanged for bamlanivimab and NTCVmab, as well as Regeneron, with that direct order form from AmerisourceBergen, and that link is unchanged. However, remember that if you live in a region that has high resistance, that bamlanivimab, atezolizumab product may not be available to you. So make sure if you are using some, you've stockpiled, you're checking your variant strains in your state, in our state, and the resistance patterns accordingly. To get sotrovimab, that is also obtained from AmerisourceBergen, but it is not in the contract with the U.S. government like the other two monoclonal antibody products are. So there is a different acquisition process, and I've put those links and phone numbers, etc., in there. Now, what they're saying is insurance, if you have Medicare Part B, Medicaid, or you're uninsured, the cost of this will be picked up. However, if you have commercial or private insurance, it sort of depends upon your insurance provider. So I think that's something to consider when you're thinking about ordering this product. Finally, the other thing I wanted to point out as to the timing of this update is this is a copy of the NIH guidelines for outpatient treatment that I think I shared with you previously. And this guideline has not been updated yet to reflect this change either. So if you're looking at the NIH COVID guidelines, you'll notice that these changes aren't noted yet, but will be occurring. So stay tuned. I will update the slide deck as soon as NIH updates their information. In conclusion, we have another monoclonal antibody product, sotrovimab, and that is not it has not been purchased by the U.S. government. Therefore, the acquisition process is different, and that makes the payment process a little different. Products can all be given IV, but Regeneron may be given sub-Q. Home is now an acceptable site for administration as long as you meet the criteria. And the source for acquiring these products is still AmerisourceBergen. The acquisition process varies if it's sotrovimab versus the other two. And remember, you need to check your resistance patterns based on the variants in your state/region to make sure you're administering the correct product for the correct patient. I'm able to answer any questions now.
All right, let's go ahead and take a moment to see if we do in fact have any questions for Dr. Connell. Go ahead and unmute your microphone if you have a question. Not seeing any at this point. We will have an opportunity at the end once again to also ask questions. So thank you, Dr. Connell. Let's move on now to the hospital intelligence report and hear from Grace.
Good afternoon, Tim. Can you hear me?
Got you just fine.
Perfect. I will just take a second to share my screen. And let me know when you can see that.
All right.
Okay, so basically since the last time I was here...
Grace, I don't have your screen yet.
Oh, okay, sorry.
And I still don't. Is it possible you have a second, it's in a second screen window that you could drag it over to the other side of where your monitor's at, or?
You know, I have it on the right screen, so it shows that's sharing on my end.
Well, let's be a little bit patient. We think it's on its way.
Okay.
It's a long way from South Dakota, you know.
That's what it is.
In the meantime, we'll admire your soothing lavender walls.
Oh. That's the vibe that I'm going for. And I mean, Tim, I actually don't have much to share, so I can actually just maybe
All right.
talk through it.
Yeah, we don't have
really
it yet.
brief.
So just proceed then. Thank you.
Oh, okay. Yeah, I'll just go ahead and you can catch on later. So overall, I think we continue with this trend of seeing the testing declining in the state. Our tests conducted in the previous week was about 8,616 compared to just over 9,000 the week of June 7th through the 13th. The positivity has continued to decrease, so that's actually good news, which actually it's even better news when you combine it with the less testing that's being conducted. And then overall in the week of June 20th, we had about 133 new cases, again, which was about a 40% decline in the number of reported cases. The hospitalizations do continue to be kind of all over the place. We've been as high as 27 the week of June 7th, and then they decreased to 23, and I believe when I checked this morning, we were at about 16 hospitalizations. And so overall, while kind of like, shifting or going up and down, we are kind of like on this sort of like downward trend, at least at this point in time. And I was actually glad to hear Dr. Connell's presentation about the expansion of the monoclonal antibodies to include that population of adults, or at least individuals either in the 25 and up BMI or the children with the 85th percentile weight categories, because truly that does encapsulate most of the state's population in terms of if you're a positive case. I think at this point in time there should be absolutely no excuse to not have access to outpatient therapies to keep you out of the hospitals. And then we did not have any reported deaths for that week of June 20th, so that's great, especially compared to the 3 deaths that we had the week of June 13th. And then so the recommendations that we are bringing forward this week to the incident command are really to continue that genome sequencing for the hospitalized cases. And this is especially because we now have the Delta variant that is presumed to be the dominant strain, or at least soon to be dominant strain in the United States. And so continuing to do that genome sequencing, and then I believe the wastewater surveillance team is doing some of that sequencing. That will at least give us a head start in terms of being able to know, especially when it comes to things like even monoclonal antibodies or those therapies, being able to inform this group what you should be anticipating in your community. So I don't know if Kirby is on the call this afternoon, but he could probably discuss a little bit more on what's going on there. And then really, I think the big news is, it's still the variants. And like I mentioned, that Delta variant being anticipated to essentially take over. And it is, at least from the few published studies that I've seen, it does look to be a little bit more likely to be transmissible compared to the UK variant, which was a little bit more transmissible than the wild type variant. But the good news is at this point, the vaccines do seem to show good efficacy, especially once you get the 2-dose for those who are eligible. And then, so Tim, can you see my slides now or not yet?
No, we don't have them.
Oh, geez. Okay. So the next slide was really just basically showing the data points of basically, the testing declining. And now it's very much a trend. You can really see clearly that over time. And even now from a day-to-day basis, we just keep seeing a declining number of tests conducted. And then for our positivity rate, again, as I mentioned, that continues to decrease. And consequently, we do have fewer cases that are being detected in the state. And the other graph that is on this slide that you obviously cannot see is just the age distribution of the hospitalizations. And we do seem to have more of the 50 through 59 and 60 through 69 as the highest number of cases being hospitalized by age. And so, again, this is a group that should be eligible for the vaccine. And more likely than not, especially knowing that, our risk of chronic disease gets higher as we get older, it would probably be more likely than not that a lot of these individuals would have been eligible for the outpatient therapies if they were willing, or at least tested in due time to actually be able to get them. So that's Tim, did you say something?
No.
Okay. Great. And then what I was actually going to share today again was what we are using as sort of like, so previously we had, we were running the RT value as one of the indicators for how fast this virus is spreading throughout the state. And so moving forward with LOA testing, because that's a metric that's heavily dependent on the testing values, we are really mostly focusing on positivity, the tests, the actives, and then the hospitalizations. And the slide that I have in front of me, which is you would have really enjoyed this slide. Hopefully in the recording you can see it. Really our tests is where we're struggling. It just looks like for every single county except Ransom County, we're sort of like in the red zone of like, really very few tests conducted per the population per capita. So our metric for critical risk is under 20 per 10,000. And for every single county in the state except Ransom County, we had less than 20 tests per 10,000 residents conducted. And so that does create some concerns of really asking ourselves, if we're not testing enough people, do we really have a good idea of what's happening in the state in terms of the spread of the virus? And the next slide that you obviously can't see was the one on wastewater surveillance, which is really, I think this is sort of like reassuring because what I can see on my end is we're sort of like in that safe yellow zone of not as much of the viral RNA is being detected in our wastewater across almost all the cities that we do sample from. And so so while testing is declining and that remains a concern, on my end, at least with the data that we have from wastewater surveillance, I think it does give us a little bit more confidence that, and also the hospitalizations, we have such few hospitalizations. And so with these two measures, being sort of like congruent, it does give a little bit of reassurance that we don't have as much of the virus circulating in the state. And then my next slide is one on the projections. And again, I've always said these are obviously predicted based on current behavior. And this has not changed much compared to that previous week. So we do continue to see this declining trend, or at least anticipate to see a declining trend. And some of the discussions that we've had about how to maybe improve on our model moving forward is building in some of that reinfection. Currently at the statewide level, I believe we have about a 0.15 rate of breakthrough cases. These are individuals who are fully vaccinated who then have become a case. And then looking ahead, really maybe trying to see how well we can track our vaccination rate, because it does seem to have stalled to some extent, and see how it does inform these projections moving forward. But overall, based on current behavior, it does look like we're on this declining trend. And then the other thing, of course, is the testing. You only project with the values that you have, or at least the values that you have for the previous couple of weeks. And so if we have fewer tests being conducted, then we're not detecting as much disease, which may obviously give us that false impression that we don't have as many cases. But like I said, overall, the wastewater is reassuring. And then the hospitalizations do tell us that we're sort of like, in sort of like a good state at this point. And I think that's what I'm going to stop there, Tim, but I will stick around for any questions. Thank you for having me. That's all I have today. Thanks.
Thanks, Grace. Let's see if we do have any questions and go ahead and take those right now. If any questions, just go ahead and unmute your microphone, please. All right, not hearing any, let's go ahead and proceed with the next item. I do want to take this opportunity to introduce the new Hospital Preparedness Program Manager. For those that aren't aware, we had the loss of Angie Strand, moved on to another position, and so we now have Gail Schwint with us. And Gail, are you in a position that you could go ahead and open your microphone? I'm not sure whether your camera is working or not. I'm not seeing an image for you, but go ahead and just provide some information about yourself, and please turn on your camera. I see you now. So if you would please go ahead and introduce yourself, please.
Hi, thanks, Tim. I am excited to be here. I join you coming from Sanford Home Care for the last year. I also have over 12 years experience working for the VA. So I'm really excited to join you and learn all about this program. And I'm excited to meet all of you.
Great. Thank you so much, Gail. Welcome aboard.
Thank you.
Next up, we have Lindsay Hoople, who has some information for us regarding the hospital data reporting. Lindsay?
Thanks, Tim. Can you hear me?
I can hear you.
Perfect. So we are currently in the process of deepening our bench for the hospital reporting. So we are going to have additional staff trained in the DOC or Department Operations Center. So if you receive communication from somebody other than Ryan Dreher, Cody Pinks, or myself, that is why. Hopefully in the next week, we should have them all trained in. So that'll be good. That's all I have.
All right, and Lindsay has a little bit of background noise going on there at this point, so she's rather quickly muted. But again, I think that just in terms of having additional staff on board helps us really maintain a data flow. We did hit a little bit of a glitch in terms of a slight pattern of interruption. We think we have all of that resolved at this point, and we're not aware that any hospitals have any issues or received any type of notification. But again, we are a much deeper bench at this point, and we'll be able to sustain those data submissions in a much stronger capacity. Next up, we have the vaccine update, and joining us for that is Abby Berg. Abby?
Everything turned on at once and my background is trying to eat me. So I apologize for that. But good afternoon, everyone. My name is Abby Berg and I work in the immunization program. I'm going to give the COVID vaccine update for today. Some of you may have seen within your hospitals or your healthcare systems that you have reduced or no inventory of Janssen or Johnson & Johnson vaccine. North Dakota and many other states have not received an allocation of Janssen vaccine for well over a month. We are actively trying to move around doses within the state. The FDA has also added a 45-day extended expiration date to the doses that we have. So as providers request them, we're moving those around the state. The reason that we haven't received an additional allocation is because the FDA has not yet approved their Baltimore manufacturing site, so there are no doses that are being approved and sent out to the U.S. So more to come on that. The ACIP, or the Advisory Committee on Immunization Practices, is currently meeting on COVID vaccines today. The large amount of the conversation is about myocarditis in young adults receiving mRNA vaccines. You are likely to see this a lot on the media today. They have made a few statements that, when taken out of context, could seem scary. But if you look at it within context, they are going to say that there's likely an association between myocarditis and people receiving mRNA vaccines, but still a very rare circumstance. So put that into context, there have been about 326 confirmed myocarditis events in 20 million doses administered. So it's a very, very rare event, but it isn't explained in other ways. But also putting that further into context, vaccination has prevented in the 20 to 29 age group in the 20 to 29 age group, there's been 2,767 deaths attributed to COVID. So we know that vaccination is important, and we know that this is a very, very rare finding. It's good that they're pursuing this, that they're looking at the data, and there will be more released upon the conclusion of the meeting. So we will get that out to everyone to make sure that you have the questions and the answers for your patients. We are also learning more about the Delta variant and how vaccines work. The Delta variant is becoming much more prevalent in the United States. Of the cases that have been sequenced, it was about 9 to 10% of those were the Delta variant in the United States. And we're now seeing more than 20% of those sequenced as the Delta variant. We also know that this variant is more contagious and very possibly more severe. But we have good news. The mRNA vaccines are about 88% effective against the Delta variant. So that's fabulous news. We know that people need to be fully vaccinated with mRNA vaccine to receive that protection. But it's great news that we have such high protection. The mRNA vaccines are also 95% effective against hospitalizations. So this is really the way to protect yourself and to stop variants is to get fully vaccinated. We're also seeing with the Delta variant that natural previous infection is not indicative of protection. And so really, even if you've had a previous infection with COVID, you still need 2 doses or a full vaccination series of mRNA vaccines against COVID. We don't have data on the Janssen vaccine, which is not an mRNA vaccine, and direct effectiveness rates against the Delta variant. The UK has some data on the AstraZeneca vaccine, which is very similar, and that showed about a 60% effectiveness rate. So still a fairly good effective rate, just not as high as mRNA. There's currently not a recommendation for those people who've been vaccinated with Janssen vaccine to be revaccinated with an mRNA vaccine because we are still seeing efficacy against the Delta variant. As I'm sure many of you have seen, vaccine rates continue to slow, so our uptake or interest in vaccine is slow. North Dakota did reach 55% of adults who received at least 1 dose. We're generally gaining about 1% per week, so that is a slow increase, but still an increase in vaccination rates. However, in long-term care settings, we are seeing an increased rate in employees, so our employee vaccination rates at long-term care has reached about 63%, which is encouraging. And I think that's all I had for our update today, unless there were any questions.
All righty. Any questions for Abby about vaccination? Well, let's go ahead then and check on the PPE supply for COVID. And here's Eleanor Hoos.
You hear me okay, Tim?
I've got you.
Great. So, Clint, you want to throw the slides up? Thanks, sir. So this period is from our last meeting of June 7th until yesterday. So we go ahead, the N95s, we currently have 2,957,380 in the medical cash. There have been 1,760 N95s dispensed since our last meeting. Surgical masks, right now we're at 2,743,850. About 1,650 of the surgical masks have been dispensed from the medical cash. Shoe coverings have stayed the same. There's no change there. Gowns are 1,175,466. There have been dispensed 400 of the gowns over this period. Gloves, we have 5,130,750, and we have 4,500 gloves that have been dispensed over the last period. Face shields, we have 1,111,335 in the medical cash. 240 have been dispensed in the last period. And goggles, we still remain at 22,405. There's no change with the goggles. And once again, our cash statewide remained very, very strong. And as you can see, we've had, just like everything else, a decrease in the amount of materials that we are dispensing. And that's pretty much all I have, Tim.
Thanks, Ellen. And that does bring us to the end of the information we prepared for you today. So let's check in with you and see what comments you may have. If you have a question that you'd like to ask any of the panelists, and Nicole Brunell from the testing program, which is the Health Research and Response Section, is also with us, even though she didn't have a presentation, so she's available to answer questions about testing. But please go ahead and pose whatever questions you may have, or if you just have a comment for the rest of the group, or want to ask questions of other hospitals, this is the opportunity to do so. So just go ahead and unmute your microphone and ask your question or make your statement. All right, not hearing any. Let me then just close out by thanking you for attending today. Remember that we are meeting once a month now, the fourth Wednesday of each month at 2 p.m. Central. And if you would like to see this program or any of the other ones that we've done, they are on our archive at www.ndhealth.gov/ET. Thanks, everyone.